Hi guys, Gabi Gayaga here. Welcome back to my YouTube channel. If you're new to my channel, feel free to click the subscribe button. Also click the little bell button that you see in the corner somewhere around here so you can be notified of when my next videos come out. If you like this video, don't forget to click the thumbs up. Let's go ahead and get started. So today we are going to talk about part 2 of my first video where I talk about careers in medical assisting, just to see if maybe this is some route some of you would like to take. So in this video I will talk about the specialty of or my experience working as a medical assistant within the OBGYN department. Disclaimer, I am not a doctor nor a licensed professional to give medical advice, so I do want to throw it out there. This is not medical advice. I am just sharing my experience with you, letting you guys know of my journey within the department and the field, and you decide if this is the right career path for you or not. Okay, so let's go ahead and get started with the difference, right? So some people get confused with the difference between OB and GYN. I could kind of see why, but let me go ahead and just lay it out. So OB is short for obstetrician, which is obstetrics, which is the practice with pregnant patients basically. So you see them from day one when they become pregnant up until a few weeks after delivery to confirm that they are healing appropriately, there are no signs of infections, and they are ready to resume life as they were before they became pregnant, or in a sense. GYN is short for gynecology. So in gynecology, you deal with everything that has to do with women's health. So we do pap smears, mammograms, other health stuff like STD checks, wellness panels, stuff like that. In most places, we'll combine both OB and GYN within one office. Some will even include other specialties like UroGyn, meaning a gynecologist that specializes in urology as well. Most of the time, they will have most of the older patients within their practice, just because a lot of the older patients are the ones that deal with most of the urinary issues, bladder issues, etc. Or even prolapses, which we'll get into later. And we also have some locations that also offer or have a gynecologist, oncologist on site, where they see patients that have uterine cancer, ovarian cancer, etc. They do the consultations, they do the surgeries, and all that good stuff. So, and then there's some places that separate both. Some offices have strictly OBs only. Some doctors have GYNs only. So it just really depends on the location, department, and company that you're working with. If you decide to go into the OBGYN route, then you don't have to worry about going through additional training, because there is no additional training once you're done with medical assisting school to get into a specific specialty. You just learn once you get the job. I got lucky enough when I graduated from medical assisting school to land a job right away, because they did need someone, and usually on their career page they did emphasize, or at least on the application, they requested to have someone with at least minimum of 2-3 years of experience, which I didn't have because I was freshly out of school. But I figured, hey, let me give it a shot, let me apply anyway. Luckily, I was able to get the job, and I was there. I have been within that company for 7 years. So what would be the difference between working with OBGYN and any other department? Well, OBGYN is a little more specific to the women's health, so you kind of have to focus everything you do around that aspect. So for example, vitals. So with medical assisting in OBGYN, you really don't have to worry about too many vitals. It really depends on the department and company that you're working with, because some places will require that you do a full vital intake. Others, they just want you to take weight and blood pressure. Others want weight, blood pressure, and pulse. Others want, just temperature. It really depends on the type of patient that's coming in and what it is that they are coming in for. Obviously, if the patient is pregnant, we do have to take the weight every single time the patient comes in, because weight gain is crucial in pregnancy. So doctors want to know how much the patient is gaining at every visit to make sure that it is within the range that they are allowed for health reasons. If they gain too much weight, it can be a health risk for them and the baby at delivery, or it can be a factor for gestational diabetes. There's just so many things involved. So taking the weight for pregnant patients within OB is definitely important. Not so much in GYN, because in gynecology, they really don't focus on weight gain, because sometimes they're seen once a year, so it really doesn't make a difference. One important vital information that is required in gynecology is LMP, last menstrual period. So it is very important that you obtain the last menstrual period, because sometimes if they're going to provide birth control, they will also ask for us to run a urine pregnancy test to make sure that the patient is not pregnant, in order for them to be able to give the medication or to run a procedure, etc. So last menstrual period is always needed at the very first appointment of a pregnant patient's visit and every gynecological visit after that. Unless, of course, the patient is postmenopausal or has had a hysterectomy. Family history is also important to have, because doctors, especially in gynecology, would want to know if the patient has a family history of breast cancer, colon cancer, uterine cancer, mostly because for birth control reasons, they want to make sure they recommend the appropriate birth control. Testing, they want to make sure that they follow up on a routine basis. If they do have a large family history of, let's say, breast cancer, they might want to have to run what they call the BRCA test to make sure that they're not a carrier, or they may have to require a mammogram. Usually mammograms are done 40 years and over, but sometimes they may have to be done sooner if they are experiencing issues themselves or have family history of breast cancer. You also have to know your insurances, because when you are working in OBGYN, there are a lot of things that need approval if the patient has an HMO. So with PPOs don't require authorizations, but some of them do require pre-certifications. So for genetic testing in pregnant patients, some of PPO insurances would rather have a pre-certification ahead of time before the patient is drawn. TRICARE also requires authorization before most services are rendered. So once you know the patient is coming in for specific service, you have to submit authorization to receive approval for the patient to obtain the service. HMOs do require authorizations for a lot of things. For procedures, Medi-Cal HMOs also do the same thing. Medicare doesn't, CareMore does. So you kind of have to be knowledgeable. Every patient's plan is going to be different. So don't expect to know everyone's coverage ahead of time. Just know the basics. Know what is covered, what needs authorization, like radiology. If the doctor's asking to send the patient over to radiology for a specific imaging service or for a specific scan, you have to make sure that the patient does not require authorization before they go. Otherwise, they will be dealing with a very hefty bill, because radiology can be very expensive. So let's cover some basics in OB. So in OB, you need to be knowledgeable the first, second, and third trimester. So in pregnancy, patients usually start their prenatal care anywhere between, in some cases, 4 weeks. Some locations will allow them to come in that early, and some can go up to 40 to 41 weeks, in which they still haven't delivered, then they will be induced, etc. So you have to be knowledgeable of the weeks, of what week to what week it starts, one trimester, and then the second trimester, and the third trimester, and every milestone as you go requires certain services. So with OBs, some locations will allow the medical assistant to do the FHTs, known as the fetal heart tones, or in other locations the doctors will do them, or they will just do it via ultrasound to make sure they're able to pick up the baby's heartbeat if they are unable to pick it up in the Doppler. In the very first OB appointment, we call, most places call it the initial check, which is usually recommended for patients that have a history of multiple miscarriages, are also experiencing any severe cramping or bleeding or any type of complications that they might have had in the past, especially if they're known to be high-risk patients. That is definitely a very early recommended appointment to make sure that the pregnancy is going well. Usually around 8 weeks, that's when the first prenatal care starts, because the baby is big enough for the provider to scan, to do an ultrasound and measure the baby and give an accurate expected due date for the patient. At that first visit, we also do the OB panel, which is the first prenatal blood draws. We check for the overall health. We check to see if the patient's dehydrated, if the patient's anemic. We check the A1C, glucose levels. We check to see if there's any infections in the urine, stuff like that. So it's just like an overall checkup, which we emphasize every single time, and we emphasize how important it is for the patient to go right after their appointment to the lab, if it's not drawn in the office, to get it drawn right away, because it helps give the doctor insight as to what the patient's health is like. If the patient's due for pap smear, we also collect for that on the first visit. Otherwise, we collect it on the 6-week postpartum check, which is after they deliver. For the most part, at 25 weeks, we also check for glucose levels. So we check for gestational diabetes. So the way this usually goes is we send the patient to a lab, or we either do it in office. We provide the patient with a very sugary drink, and the patient has to drink it within 5 minutes or less without drinking water, chewing gum, or anything immediately after drinking the sugar drink. Within the hour of drinking that sugary drink, we have to draw the patient's blood. And that tells us how well the patient's body is able to break down the sugars. Because after 19 weeks, the pregnant patient's body breaks down sugars a lot differently than it did before the patient was pregnant. So patients can be prone to gestational diabetes if they're not taking care of their health. If for some reason the levels are high, we do a 3-hour glucose check. So the patient is basically just drawn every hour. They have to be fasting for this test. Blood will be checked every hour for 3 hours to see how their body is breaking down the sugars. So if they pass the test, yay! If they do not, then they have to see a nutritionist, where they are told how to take care of their health and the risks of not following through. In some cases, they will be given a glucometer if they do end up with gestational diabetes, etc. At 28 weeks, we usually start offering the Tdap vaccine, which is also known as whooping cough. Most places start administering at 28 weeks because it gives the body enough time to create the antibodies. So once the baby's born, mom can pass those antibodies down to the baby via the breast milk. At 36 weeks, we start collecting a swab. We don't, doctors do. So don't walk in with that expectation that you'll be swabbing patients. But doctors will be collecting a swab called the GBS. It's a swab that checks for bacteria that is common. It is not an STD, and we send it out at 36 weeks. Why at 36 weeks? Because if it is present, then they want to make sure that they treat it before the baby is born, especially if the patient will be having a vaginal delivery. At that point, after 36 weeks, depending on the location, some doctors will do pelvic exams to see if the patient is dilating, or they will check to see which way the baby's facing. Usually some places wait a little later, until like 37, 38 or so, because babies are shifting all the time. So just because one week they're facing one way, the next week they may be facing another. So it just really depends. It's up to the doctor's discretion, and each practice works differently. Now for delivery, once the patient has delivered, if they had a C-section delivery, then they do have to come back 1 week after the delivery so the doctor can check the incision to make sure that they're not developing an infection, there's no oozing, no pain, or to determine if the patient will be needing additional time off. Then the patient will come back 5 weeks after if they had a C-section, or 6 weeks after their vaginal delivery for their 6-week postpartum check. This is usually the time where they do a questionnaire as well. They're checking for postpartum depression. Postpartum depression is a real thing, guys. And we do see a lot of patients that have delivered. Their hormones are going crazy. In pregnancy, your hormones are going crazy. And after you deliver, your body's trying to adjust. Your hormones are trying to adjust. So the patients have a hard time So this is the time where we usually catch it. Sometimes depression can exist during pregnancy, but it is mostly seen after delivery. So this is the time where we want to make sure if we catch something on the questionnaire, our job as a medical assistant is to notify the doctor of what is going on so they can treat it. Most doctors will catch it as well. So even if the medical assistant doesn't report it, they will definitely ask for that questionnaire and see how the patient's doing so they can follow up with the proper treatment. Now, let's go ahead and talk about GYN. Now, I know you guys are thinking like, why? That was just OB? Yeah, OBGYN is definitely huge. There's a lot going on. GYN is probably a little more taskier, I would say, because there's a lot more going on. So in GYN, there are a lot of procedures, a lot. So it's like they're like mini surgeries almost on a daily basis. So when I did halfway into my medical assisting career, I wanted to pursue a career as a surgical tech because I love doing procedures. I love like surgeries. So these are just minor surgeries, so nothing gory, nothing like too bad. We go from like minor stuff, it's like punch biopsies or whatever it is that they feel like they need to send out to the lab. We do leaps, we do endometrial biopsies, we do IUD insertions, SIS, saline infused sonograms. I mean, there's tons of stuff that we do, and we need to know which instruments we have to have ready, what supplies the doctors will need. We have to also have lidocaine, which is like a numbing medication for the patient. There's just tons of stuff that you need to be aware of when you're working with GYN. So it can be overwhelming if you do not have experience in OBGYN. Let's say you're transferring from another department to GYN. It can be a little overwhelming because there's a lot of new stuff you do need to know, and you kind of like everything works like quickly. So you have to be fast. You have to know what you're doing. You have to, what I do that helps me is I put myself in the doctor's shoes. I think, okay, what if I'm the doctor, in what order am I going to do? Okay, I need the speculum. I'm going to need lubrication for the speculum. If I'm doing a colpo, if I'm going to do a colposcopy, I'm going to need my scope. I'm going to need acetic acid. I'm going to need swabs to clean it up, look inside. Then I'm going to have my biopsy bottles. And then if the patient's bleeding, then I can have silver nitrate to stop the bleeding, or have Monsols ready. You have to kind of like see, like the more you work in the department, the more practice you gain, the more you start to see the doctor's routine, and that helps you remember not to forget certain things, because doctors do not like it when you forget something, and like in the middle of the procedure you have to leave the room to get what you need. Most of them won't say anything because they're still busy doing what they got to do, but I mean, they need that extra help in the exam room while they're, they need someone handing them the instruments, someone collecting the samples, putting them in the biopsy bottles while they're working on the next thing, and so on and so forth. So it can be overwhelming, but do not be discouraged, because anyone can do this. It just takes time, it takes practice. The more you do it, ask questions. If there's something you forget, if you get confused or you're not sure, ask. And remember that in every procedure that you do, you need to have a consent form ready. So every location will have different consent forms. That's a permission slip from the patient giving us permission as the practice to perform this specific procedure. In most cases, before any procedure, we also need to run a pregnancy test to make sure the patient is not pregnant. If the patient's pregnant, notify the doctor, and they will weigh the risks as to continue with the procedure or not. So leave that up to the doctor. Your job is just to run the pregnancy test, have the patient fill a consent form, and then let the doctor take it from there. Another thing in gynecology that I would like to take the opportunity to mention is the difference between a pap smear and a well woman exam. Now, there is a huge difference. Pap smears is a sample. It's like a little brush that they use to put on the cervix. They circulate it to collect enough cervical cells, send it to the lab, and it checks for abnormal cells or HPV, which is an STD. If that comes back positive, then they have to take the next step. Whether they repeat the pap smear, they do a colposcopy where they look at the cells under a specific scope, or they do a leap, depending on the previous results. A leap is where they take samples of the cervix and they send out to pathology. A well woman visit or a well woman exam feels a lot like a pap smear. It feels like it, but it's not. So this is the difference. A well woman visit, it consists of a breast exam and a pelvic exam. The doctor will do the pelvic exam to make sure there are no physical abnormalities that they can feel. They check the ovaries to make sure that everything looks good, and they're just checking. A pap smear, they're collecting a sample and sending it out. So some patients will get this confused. Some patients will think that just because they had their well woman visit or well woman exam, they had a pap smear. That's not right. So right now, if you have had a normal pap smear, your pap smear will be collected every 3 to 5 years. But if you have a history of abnormal pap smears, they will either collect it every 6 months or every year, depending on what the doctor found and your history and all that good stuff. But if you you can get it done sooner if you like. Just notify the doctor. I would like to have my pap smear done sooner. I know that if you have a short-term disability insurance, some short-term disability insurances will pay you if you have your pap smear done every year, if you have your mammogram done every year, if you have your cholesterol check every year, they will pay you to get that checked on an annual basis. So if you want to get that paid out, it's okay to tell your doctor to have it collected, even though you're not due. But some insurances, like CareMore and Medicare, those will not pay for it. So you will receive a bill. So just check with your doctor, see what they recommend. If it's okay, if your insurance covers it, go for it. But otherwise, it's not needed for every 3 to 5 years. In gynecology, we also focus on birth control. So we do birth control consultations where, as a medical assistant, all you have to do is just take the vitals, get the patient's last menstrual period, collect a urine sample so you can run a pregnancy test, because there are many routes that the doctor might want to go. The doctor might, depending on their insurance, obviously, if the insurance covers it and does not require an authorization, for example, like PPOs, if the doctor wants to do an IUD insertion, we have hormonal and non-hormonal kinds. You want to make sure you have that ready. You can pull it and the doctor can be ready to insert. We also have an Nexplanon, which is a little implant that goes in the arm. We also have injections, Depo injections. You want to make sure you administer that. You cannot administer the injection if the patient is pregnant. We also have birth control pills. We have the newborn rings, and then there's the options such as tubal ligation, which doctor will have to do in surgeries. We also do, we don't do the mammograms, but the doctors take care of the mammogram orders. So the gynecologist is a doctor that does take care of that. Family practice also can put in the order, but most of the time when the patient's coming in for their annual exam, their well woman visit, that's when they order it, because they're also doing a breast exam. So if for any reason the doctor feels a lump or feels some sort of abnormality while doing the breast exam, that's when they can submit the order. They can submit a diagnostic mammogram where they identify the specific location of where they found that lump or the abnormality, and the technician, when they go to get their mammogram done, can focus on that area to make sure they rule out anything bad. We also do procedures such as DNCs. We can either do them in the office or we can do them in a hospital setting, depending on how bad. DNCs can be done for many reasons. Some of them can be done because the patient's having abnormal bleeding, or maybe the patient might have had a missed abortion, in which case they will have to do that in a hospital setting. We also have to understand what a hysterectomy is. We don't do hysterectomies in the office because it has to be done in a surgical setting. So as a medical assistant, you really don't have to do anything there, because the doctor will take care of scheduling the surgery and doing all that surgical stuff. But the only time you will need to know about the hysterectomy is if the patient is coming in for a gynecological service and you need to know when was the last menstrual period. If the patient says they had a hysterectomy, then you know the patient has not had a period because the patient doesn't have a uterus. You don't have to have that information available, but you will have to document when the patient had the hysterectomy for the doctor's records. Urogynecology. Now in urogynecology, some gynecologists will also take some of these tasks on if there's not one available, but they can also, urogynecology, they do what they call PVRs, post-void residual, where they take a catheter, they put it inside the urethra to release some urine. They will also do pessary fittings. So for like prolapse, they will do the fittings. If the patient comes in with a pessary, they have to make sure that they have the pessary cleaned every 3 months. So in some practices, the doctors will clean the pessaries, and others, the medical assistant will clean the pessary and just hand that over to the doctor for insertion. They also deal with incontinence. They also work with UTIs. And UTIs, as a medical assistant, you want to make sure if the patient's complaining of a UTI, urinary tract infection, that you collect a urine sample, you collect for culture, you send it out to the lab, you notify the doctor. You have to do a urine dip to let the doctor know what the levels are, like pH, proteins, and to see if there's blood present in the urine. Doctors in some cases will prescribe antibiotics and send the culture out to the lab and to see if the bacteria was resistant to the medication, in which cases then they will change the medication to one that is appropriate. But you just want to make sure that you are one step ahead of the game, that you know that if the patient's having a UTI, you know you have to collect the urine, you know you have to do a full dip, you know you have to report to the doctor, and the doctor will take it from there. In urogynecology, doctors will also do what they call a cystometrics. In some cases, they will do cystometrics with Botox. As a medical assistant, you have to be knowledgeable of the procedure. You need to know how to put the equipment together. I will admit, it is a little intimidating when you look at it. There's so many things you have to click together and set up. And you have to be very careful because the equipment is very fragile because there's a camera at the end. Not all specialties have this, but if you do work in an office that works with cystometrics, you want to make sure you're careful with the equipment. For the most part, LVNs normally tend to work with urogynecologists because there's so much stuff involved that they would need to help with, like numbing and stuff like that. But in some cases, medical assistants will have to be present to assist with that as well. Well guys, hopefully all that information was very helpful to you. Hopefully it helped you guys as much as possible. If you really enjoyed this video, please click the like button. Don't forget to click the subscribe button as well. And if you know of anyone who can benefit from this information or would be curious about working in the OBGYN department, feel free to share this video and see how they like it. Thank you so much again for joining me today, you guys. I hope to see you at my next video. I'd like to hear some feedback, so feel free to leave some comments below. I'll see you guys in my next video. Bye.